So today's talk is about general pharmacology therapy of asthma. We already talked about NICU treatment of asthma, whether it's an acute exacerbation or ventilation-wise. We already talked about general approach of non-pharmacological therapy. And today we will be talking about the pharmacology. Now we can also talk about emergency treatment of asthma, which is non-PICU admission in emergency or in the ward what happened. And also we can talk about the general ward management of asthma, but I don't think it will be much different from treatment in an ICU, other than the setting and the difference and the resources are different. So today anyhow we'll be talking about pharmacology of asthma. So the objective is to categorize asthma, as we talked earlier, categorize the severity, and then we'll talk about the treatment itself, and then we'll talk about which one is effective or not. So the mainstay of management of asthma is medicine. And the best way, which approved by evidence, is a stepwise approach. And when we use the stepwise approach is to support us making the decision, not to exactly dictate the stepwise management. Because always, in addition to being supported by stepwise approach, we always need to use our clinical judgment. So the stepwise approach is you increase the medication level, the type and the dose until you get the control. And when you get control, try to decrease the dose and the type and the number of medication to minimize the side effects. And the adjustment, whether it's stepping up or stepping down, is done with each visit. So the first step to control, to treat asthma, is to classify it. So if a patient comes to you first time, you need to classify the asthma before start medication. If the patient is already on medications and he's first time seeing you, you can categorize the severity depend on the number and the dose of controlled medication already in use. So when you start pharmacology, you have two options. Well, actually three. Either comes in an acute attack. We talked about how to approach asthma in a severe exacerbation. Or he comes to you, or she comes to you without an active exacerbation. It comes to you, either you suspect the diagnosis, never treated before, or it comes to you already on medication, either is not controlled well or no compliance. So if it comes to you for the first time, you need to categorize the severity. If it comes to you already, then use the medication that the patient already on to categorize the severity and step up or step down depending on the situation. So the severity is the severity of asthma, not the severity of exacerbation. The severity of asthma is a class, as we talked when we talked about general approach, is depending on the symptoms that the patient describes. And the patient should recall it within last 2 to 4 weeks prior the admission. In addition to the, if the patient age is enough, we use the pulmonary function stat, the peak expiratory flow rate, the forced expiratory volume first second, and also the ratio between first second and forced vital capacity. So the symptoms, the function, and the other way is the number of exacerbations that need either admission to the hospital or need oral steroid. That's also kind of classified. And we have a very nice video. If you click here, you can go to the severity classification. I'm not going to go through it. And this is the classification. We start first by intermittent asthma, and we have already the classification. We've talked about it in the other presentation, but it's basically is if the symptom during the day less than 2 days per week, or during the night more than 2 days per month, or use of bronchodilators more than twice per week, and usually does not interfere with daily activity, with normal pulmonary function, or more than 80% of the best normal or best personal. And usually the patient should have one exacerbation or less than one exacerbation per year, or using corticosteroid less than once per year. This is considered an intermittent asthma. Any features more than this, consider non-intermittent, consider persistent. And persistent, of course, divided by, categorized by mild, moderate, and severe. Now, when we said the use of short-acting beta agonists during the day, we're not including prophylactic, like exercise-induced asthma. So that will not be considered when you categorize the asthma. And also, the bronchodilator should not be included in the classification of severity if the purpose for other preventive asthma, like you use a steroid when, for example, you encounter allergen like cat, or when there is a high prevalence of respiratory viral infection, then you need a bronchodilator to prevent the exacerbation. These are not included. And if you want more about classification, you can watch the video. So if it's more than that, it's mild persistence, and also there's a classification of mild persistence. It's more than twice per week, more than 2 nights per month, and you need more than 2 days per week for bronchodilators, and it's a little bit interfere with activity, and also you have normal pulmonary function, but you can use the exacerbation, whether admission or steroid, like 2, then should not be less than 2. If it's less than 2, it will be like more or less considered intermittent. Any feature more than that, it's considered more than persistent. So we have moderate, and we go on with the symptom. So again, I'm not going to go through the details because we already discussed that. But with moderate, you'll have abnormal pulmonary function. Whether it's the forced expiratory volume in first second, which will be like between 60 to 80 of the best personal. And also you have the ratio between FEV and FVC below normal. Severe persistent is like more symptom, and the main is that the pulmonary function is less than 60, and use of short-acting beta agonist almost daily. So what is the initial therapy? If patient present with exacerbation, then you need to start steroid, in addition to the symptom reliever. In patient without previous treatment, use a stepwise approach as we discussed. And the stepwise approach is a guideline, is a support, is not replacing your decision. And the severity, as we said, by symptom, as we discussed, or if the patient already on treatment, is by the type of treatment. So what is the initial therapy during acute exacerbation? This is acute exacerbation. And you can see the symptoms, type of it, and what does mean the symptoms. So we've already discussed that. And again, if you remember, when we talk about classification of asthma, we classify it according to the symptom, pulmonary function, but also we classify it according to the risk factors. So how we treat? If it's intermittent, we go step 1. If it's persistent, we start with step 2. It depends. On it's mild, moderate, or severe, we go to step 3, and when it's severe, step 4 or 5. But when you reach the level of step 3, always consider steroid. When you use, remember, when you assess the severity, always remember to recall up to like 2 to 4 weeks prior the evaluation visit. So this one was more than 12 years. So what is the initial? In uncontrolled asthma therapy, if already on medication, adjust according to the need. Again, remember, it's 2 to 4 week assessment. History, how we assess a patient when he is like old enough, we use history, or we can use validated questionnaires when the patient is more than 12 years. We can use also the pulmonary function, and also use this risk factor. What's the meaning of well-controlled asthma? If the patient is calm and well-controlled, then we need to wean a little bit or step down the treatment. We call it well-controlled. So when it's well-controlled, we step down. When it's poorly controlled, we stepped up. Very poorly controlled asthma. So if it's poorly controlled, we step up. If it's good controlled, we step down. If it's very poorly controlled, we have to escalate the therapy very rapidly, and probably we will skip. We will skip 1 step or maybe 2 steps. So always, when the patient come back after you step up or step down, you validate your treatment, because remember, the asthma management is dynamic. So what is step 1? The step 1 is using a quick-acting inhaler beta-2 selective adrenergic agonist, and should be taken by the patient as much as it controls the symptoms. So here is the stepwise of management or initial management in patient either coming first time or it's underly treated. So in intermittent one, as we said, it's twice per week, less than twice, 2 nights per month, a need for short acting less than twice per week, not interfere with activity, and if it's more than 5 years, then probably the normal pulmonary function. So step 1 is using short acting beta agonist as required, not scheduled. If the patient need, you go to step 2. And in step 2, you use step 1 plus low dose inhaled, low dose corticosteroid inhaler. The alternative is we use chromoline and or leukotriene agonist. Or you can use nidocromil or thiophanate. So this alternative is not advised. So the best is to use short-acting beta agonist on need and low-dose inhaled steroid. And we will talk about what the meaning of low-dose later. If you go to step 3, the preferred, if you go with low-dose inhaled corticosteroid plus, now here and here you are using the long-acting beta agonist as a reliever. But in here, in step 3, is not more an reliever. It will be scheduled beta agonist in addition to the low-dose inhaled corticosteroid or leukotriene receptor, leukotriene activators or thiophanate. Or instead of all that, use a medium dose inhaled corticosteroid, which means you don't use the long-acting as a scheduled dose, but use only a steroid and use short-acting PRN. When you go to the step 4, use also medium dose, like in here, but you add long-acting as a schedule. Or medium dose with other reliever. In step 5, you go for high dose with long-acting beta agonist, or use high dose plus relievers. In step 6, you use a high dose steroid, long-acting beta agonist, and you add oral steroid. So you go up and down according to your assessment. And remember, if the patient first time, you categorize it according to severity. If the patient is a returning patient, then you categorize it according to the use. Whatever he's using, you assess according to the scale and then use it. Now, guys, do you have a question? Or it's clear? Any question? Now, if there's no question, then remember when you reach step 4, 5, and 6, probably you need to consult somebody, an immunologist or a respirologist or asthma specialist. Now, this is the treatment for older than 12. It's very similar, but in step 5 and 6, you need to consider omalizumab, whose treatment for allergies, for patient who has sensitivity, and you can single out the allergic potential. That's the only difference. The rest of the treatment are the same. Again, the treatment for patient less than 4 years is the same, but here you need to depend more on the steroid. And the reason for that we will talk about steroid. I just said that. We will talk about what's the meaning of high, low, or medium dose steroid later on. Just remember, it's low dose or high dose. We will talk about in details. So the difference here in patient less than 4 years is it's more inflammatory rather than bronchospasm. So it's more you depend on anti-inflammatory and you depend more on steroid. Otherwise, the stepwise management is the same when it's 0 to 4 years of age. So step 1, use short-acting intermittently as a PRN dose, or then step 2, you start low-dose inhaled corticosteroid, or use cromolyn or montelukast. In second, you use a steroid or montelukast, you remove no thiophyllene, no others. Or in step 4, you go to medium dose, but you add some other bronchodilators. In step 5, you go high dose, and you add other bronchodilators. And in step 5, you go high dose, but you add systemic steroid, and you can add other bronchodilators. So it's almost close, but remember here, more you depend on the steroid when the patient is less than 4 years. Now, we've talked about what is low dose and what is high dose. I just put a list of all potential medications that can be used as inhaled steroid. Now, remember, it just like looks very naive to remember all that. You don't need really to remember it because you can have it in front of you. And I myself, even if I remember it, I review it before I prescribe it to my patient. But I put it here just for review, not to memorize. You can see that you have the baclomethasone HF, and this is the meaning of low dose. So you give 80 to 160, even if the buff is 40. So you have to give 2 puffs. Even if it's 80, then if it's one time you give 80, if it's twice you give 2 puffs. And medium dose means that 160 to 320, and high dose means 320. Can you please mute your voice? There are many types. So there is 40 mic per puff and there is 80 mic per puff from this medication. And so it depends on which level you are. You can use 1 or 2 puffs. Can you please mute yourself? So beclomethazine HFA is a different, because it's a different puffs. It's a different concentration. We have the budesonide, or what would you call Pulmicort, and there are different types. So if you need a high dose, probably you go to a higher concentration. It only decrease the number of puffs for the patient. We have budesonide, Pulmicort, Turbohaler, and there are different concentration. We have the cyclicinide, Alvesco, and the different concentration, and the definition of high, medium, and low dose. There are different types of concentration. You have the flunisolide, Aerospam. You have the fluticasone. So there are different types. There's propionate, Flovent, and there are different concentration and the level of severe. And you can see some of them, they don't have high dose, so you should not use them. Other types, it's all prescribed, all types of different concentration and different company of fluticasone. There is fluticasone furanate, because the other one was propionate. And you can see it's all mentioned here. The mometasone, and different type of it, different concentration, and how we define high and low level dose of steroid. And these are the different types. Now, when also you start stepwise, so if categorize your patient as intermittent, and you started step 1, so you started, as we said, step 1 is short acting on need, but also you have to prevent the exacerbation factors. So if it's an exercise-induced asthma, then the patient should take an inhaler prior, about 10 to 20 minutes prior to the exercise. And this should not be included in the next assessment. So when you do treatment for prevention, you don't consider it for classification on next visit. When you go to step 2, so it's much better to go with long-term controller, which is low-dose steroid, as we discussed. And uses of inhaler is much better than using a nebulizer. It's mobile, there is no electricity, you don't need hospital setting. And remember, it can be used as young as 6 months by using appropriate spacer. So there is no need, there is no reason to exempt one person or one patient from inhalers, and try to minimize. And remember, when we talked about nebulizer, there are 3 types. They are not functioning well. The percentage of the delivery is low. The wastage is high. So always using an inhaler is much better. So they found using inhaled corticosteroid in step 2, severity asthma, which is mild persistent, decrease the symptom, decrease the need for PRN bronchodilators, improve quality of life, improve feeding, decrease the incidence of hospitalization, and prevent the progression of disease to step up. If you don't have, you cannot use the steroid for any reason, then you go for alternatives. So you go for leukotriene receptor antagonist, which is the favored one, but also you can add thiophyllene. Now, I personally don't recommend thiophyllene or aminophylline because of the therapeutic, safety therapeutic level and need to monitor and complications. So, but you can add chromoglycate, and remember, this is not related to relieve the symptom, because always you have to add PRN. Should you have always to advise them to use the short acting to prevent the symptom. So you should not stop that despite your level. So the short acting should be used for relieving symptom whenever needed, and also if there is a trigger factor. and then use it next time to assess. Remember, when used for trigger, is not considered for the severity. Now for step 3, it's still low dose glucocorticosteroid, but this time you add long-acting beta agonist, in addition to the short-acting that you are using it on relieving symptom or to stop the trigger. By using this strategy in step 3, it have a more effective and less side effect. However, you can remove the long-acting, and instead of low dose, you can do a medium dose inhaled corticosteroid. However, this is less effective, more side effect of steroid. Or you go for alternative. If you cannot use the steroid, then you go adding leukotriene modifier in addition to the long-acting beta agonist. But you can add others like lipoxygenase. This is a new one. I don't have experience with it, but also you can add theophylline. I don't usually prefer theophylline, and it's rarely ever needed. Now for step 4 and 5, I would consider it severe. So now I go with medium plus long-acting beta agonist, or I go with high-dose glucocorticoid, or I add systemic steroid. And at this point, you need a triple drug. So you need long-acting, inhaled, and maybe you add systemic short course of steroid. If there is allergy and the patient is old enough, then omalizumab is a good choice, which is NTE therapy. It's very difficult. It needs specialists. Can you please mute yourself? Sharwet, what is your second name? Can you please mute yourself? Mute yourself, please. So omalizumab is difficult to implement because you need allergy skin test, you need an in vitro management, and you need serum immunoglobulin level. Also, always consider when there is eosinophilia, the omalizumab can be used. When there is severe asthma and you're more than 5, you can use that. So there are different types. There is like mepolizumab and there is reslizumab. It's different drug names. That's not a big issue. It's a potent chemotractant factor for eosinophils. And as I say, it's indicated for severe asthma, especially if you have eosinophilia in the blood with the, and is not being controlled by the conventional therapy. There is something called bronchial thermoplasty, and it's a device-based intervention available. Can you please mute yourself? Device-based intervention available to treat severe asthma. So this type of therapy, a thermal therapy, applied to the bronchial wall through specific catheter and trying to relieve the contractility of bronchial muscle. I don't advise it. It's still investigating. I don't think you need it if you control your asthma very well. Can you please mute yourself? I don't know why it's difficult to do that. Let me mute him. Okay. Now we've talked about the management. Now I don't want to talk about the dose of steroid or a dose of fluconazole. I think you can review it. If you need copy, I can forward it. So I don't want to waste my time and your time with that. So stepwise, reduce symptom, improve health life, and decrease side effects. And have been noticed that guideline-based management, not the based management from your mind. So you put the guidelines in front of you and you follow it. It improves symptom, it increases quality of life, it decreases the side effect, and it decreases the number of admission and exacerbation, and the number of time you need systemic steroid. When to refer, I don't know whether there is a pulmonologist over there, but these are the indication where to refer. If you have life-threatening that need PICU admission, if you need steroid more than twice per year, if you reach step 4, if you are more than 5, or step 3, if you are less than 5, or you cannot control the asthma within 6 months, or you're giving treatment, there is no response, or you're not sure of your diagnosis. Other conditions associated like polyps, sinusitis, rhinitis, or allergic bronchopulmonary aspergillosis, chronic obstructive, vocal cord problem, you have positive allergy test, when you need a more like allergy test, when you need a bronchoscopy, or when you need to do a pulmonary function test. These are always, it's recommended to do the management at that step with the specialist, allergist, or pulmonologist, and it should be like, it's better to be a combined treatment. If you need omalizumab or mepolizumab or risankizumab, then it should be joint treatment. Of course, if you are doing these fancy type of treatment, you need specialists. Again, if you have a potential trigger at the school or at work, then you need a specialist. If the asthma affecting the child or his family, then probably you need referral. And at the same time, the patient, asthmatic patient, can have any other problem, so you need to treat that with other specialists appropriately. And I am done, and I am open for question. Any question? Questions?
Okay, Dr. Yahya, thank you so much for this nice presentation and lecture.
Yeah, thank you very much.
Can I comment, please?
Yes, go ahead, please.
But you didn't mention the drug delivery devices as spacer and.
We talked about that already. If you go back to the other lecture, we've talked about the delivery, each type. We talk about how to educate the patient. We refer to the videos, to the guidelines. And we've said that to teach your patient, you need to teach yourself. So I've mentioned about 12 inhaler and stepwise how to start them, how to maintain them, and how to teach your patient. And also we refer the video of each device, how to do it.
Okay, thank you.
You're most welcome. Any more
thank
questions?
you, Dr. Yahya. Can I ask you a question?
Go ahead, please.
In your experience, do you prefer to increase the inhaled corticosteroid or add another drug?
Sorry, which patient? I missed that. Your voice was not interrupted.
I will repeat. In your experience, do you prefer to increase the dose of glucocorticoids or add another drug in every step?
Okay. If patient is below 4 years, I advise to increase the dose of steroid. If the patient above 4 years, I advise you to add other bronchodilators. That would be my approach. So in step 1, I would use intermittent PR doses for symptom relief. In step 2, I go with low dose. If I don't control and patient less than 4 years, I would go to the medium dose inhaler. If I need more than medium dose, I would add bronchodilators to it. So I would treat patient less than 4 years, 1 step below. Sorry, 1 step above. While a patient more than 4 years, in step 2, instead of going, in step 3, instead of going to medium dose, I would stay on low dose and add a scheduled short acting, or instead of short acting, I would add long acting beta agonist.
Thank you, doctor. Thank you.
You're most welcome. And I'm sorry, I don't remember the doses. Usually I don't remember. Even if I know the dose, I review it before I give it. And I think we are living in an era, it's naive to remember these medications because there are a lot. And with more knowledge, you can see different ages have different doses. So I advise everybody to start reviewing these doses using online softwares like Lexicon, where it tells you all the doses. So I'm sorry, I usually don't write the doses, but the size of the spacer. Now, the size of the spacer, you know, you remember the spacer is just a tube, connect the inhaler to the mouthpiece. And the mouthpiece can be just mouthpiece that the patient can bite, or it can be a tet that patient can suck, or it can be a mask. So it depends on the age. Like if the patient is less than 2 years, I would use a tet. If the patient from 2 years to 4 years, I would use mouthpiece so patient can grab. If the patient more than 4 years, I would use a mask. So the size depends on the age, actually not. And because the way the spacer is oriented, the patient should get all the medication. So the number of spillage is low. However, when you start to use mask, and remember, we talked about oxygen delivery system and we talked about different masks. It depends on the type of the mask you use, the loss will be. So is it like rebreathing mask or non-rebreathing mask, or it's partially rebreathing mask? If you don't know these difference, you can go to the oxygen delivery lectures and you will know the difference. So basically, if the patient using mouthpiece or teeth or a sucker, then usually there is no loss because the spacer is one way and the patient has to breathe alone. So you put, and there's one way, air coming in and going to the patient. And when the patient breathes out, it goes from a different way because you have safety exhalation valve and you have one-way valve. So there should be no wastage, but I guess the more you clean the spacer, the better. The more you dry it after you clean it, the better, because more wet, it can clog some of the medication. But the loss is not like the surfactant giving, or nebulizer. Usually there is no loss with the inhaler. Any more questions? And please remember, I am not asthma specialist, so my knowledge in asthma is really limited because I am intensive care physician more than like, I do general pediatric, but my general pediatric is limited. So maybe if you ask me some questions and the answer is wrong, if other specialists answer them appropriately, then probably they are right and I am not. You're most welcome. Any more questions? If no questions, I am going to close.
Is there any rule for antibiotics?
Sorry, again?
Any role for antibiotics in management of asthma?
Absolutely.
As infections are.
Absolutely not.
Is there any role for antibiotics in the management?
Absolutely not.
We know infection can exacerbate.
I've answered you. Absolutely, there is no zero rule. Zero. There is no only even 0.5% need for antibiotics. Usually the exacerbation are viral. Usually if it's infection, superimposed infection, then that's a different issue. Then you should have a blood culture, you should have CRP, and you should not give oral medication and send patient home. If patient is asthmatic and has pneumonia, then, because that's the only reason of triggering it, it's infection of upper airway. And if it's an infection of lower airway, because infection of upper airway will not trigger asthma. So if the patient need antibiotic and he's asthmatic, then mostly he need admission. What about the last case scenario, which time we will discuss? Which case? Sorry, I missed which case you're talking about. I have 5 groups, so there's different questions, so I can't remember. Wahida, which case you're talking about? which case you're talking about? I can't remember. Are you talking about the ventilation case, ventilation scenario? Oh, that's the ventilation, that's a different issue. That's a PICU sort of stuff. So I will give time and then I will answer. And the reason I've done it in this way, because you guys are very focused. I don't like focused physician, because focused physicians are too dangerous. Focused physicians are too dangerous. And the problem is a focused physician. So you know your stuff, you go directly. And therefore you might be right, but you might be wrong. So when you do that, you're not safe. You guys don't consider all the circumstances when you manage your patient. So when I do it, and if you looked at the second episode, I've discussed all the possible, because every say, well, we ventilate, we do gas. But nobody remember, maybe your CPAP is not working. So we will pause within time this scenario until we finish it, and then we will pause another case. Okay, well, I'm done, and thank you for attending, and my apology because I was late today, stuck in traffic, but I made it as short as possible. Thank you very much.